We have now officially completed our discussion of acute renal failure. Our discussion now takes us into chronic renal failure. One of the most common causes, in fact, would be diabetic nephropathy. It is important that you absolutely know the stages of end-stage renal disease. Under the stages, as we progress into 1, 2, 3, 4, and 5, we have killed our kidney. So chronic renal failure, as it progresses through stages 1, 2, 3, 4, and 5, the later the stages, the kidney absolutely has no chance of recovering, and your only choice at this point perhaps is a dialysis type of treatment or perhaps even transplant. Now what we'll do here is go into stage 4 and 5. Stage 4 and 5 of chronic renal failure, severe decrease in GFR. You can expect there to be hyperkalemia, hypertension, metabolic acidosis, things that we discussed earlier. What is it called when you find the signs and symptoms with chronic renal failure? Is that azotemia or is it uremia? That is uremia. As we go into stage 5, we have now officially entered end-stage kidney disease, renal failure. We have all the signs and symptoms of uremia. Really, as far as your GFR, take a look at this. Less than 15, and GFR normally is at 100. Okay, pretty massive in terms of death. Okay, now, what are we going to walk through now? We're going to walk through the patterns that you expect to find with chronic renal failure. The uremia, if untreated, what does that mean again? Once again, maybe perhaps you're thinking about hypocalcemia, secondary hyperparathyroidism, renal osteodystrophy. I'll talk about all this, not to worry. You'll find an increase in creatinine, and your azotemia here, well, you have more of an increase in, well, your ratio is going to decrease, but the creatinine will be elevated automatically, and that becomes important for you to understand. Remember, what's your normal creatinine? 0.6 to 1.2, 6 and 12. As your kidney starts dying and you get older, remember, the filtration of creatinine decreases. That's what you want to keep in mind. Your second order testing is effective GFR. The disease group will be end-stage kidney disease, stage 5. Oliguria, what are you thinking about here? A couple of things. Remember when we had acute renal failure and we had the initiation phase and the maintenance phase. It was during that time where in acute renal failure you did have oliguria. Could you have oliguria with chronic renal failure? Sure you can. What is the actual definition? Objectively, less than 400 milliliters per day of urine being produced. Your second order testing here would be urine creatinine ratio. It would be depressed here. And then therefore you're thinking about acute kidney injury, most common cause, ATN, ischemia. Non-oliguria, inpatient. Here you find an increase in creatinine. Here you're looking for that fractional excretion of sodium. So your patient is non-oliguric, but you're suspecting acute renal failure. You are going to look for increased creatinine in hospital. This is no joke. Next, fractional excretion of sodium here is going to be, well, if it behaves like acute renal failure, it is then going to be increased, very important, and this then puts you in a group of acute kidney injury, inpatient. Hematuria. With hematuria, well, the pattern here could be either nephritic or nephrotic. It's usually nephritic. You end up finding RBC Cas as the objective measure. Your protein here is greater than 3.5 grams. Well, renal biopsy, not post-streptococcal, puts you in a disease group of glomerulonephritis. Now, hematuria, for the most part, is usually only seen with nephritic, but there's every possibility that you might find it with nephrotic. But the magic bullet point here is the protein, urea, being greater than 3.5 grams. Make sure you spend a little bit of time with this table and you go through, what is my presentation? What's the pattern that you can expect? Where is my patient? The objective measures, the second order testing, and the disease group that this puts you in. Presentation. Well, if it's edema, nephrotic syndrome, we talked about objective measure, nephrotic. Second order testing, renal biopsy, not for minimal change disease or even diabetes. Fever, costovertebral angle tenderness or pain. CVA, costovertebral angle tenderness. Pyelonephritis, what do you expect to find objective measure? WBC cast. You're thinking about neutrophils. You do a culture. Pain, colicky type. This is not the costovertebral. Here, You're worried about your renal stones or calculus. And we have imaging and hematuria, and this we'll talk about in the subsequent topic of nephrolithiasis. Increased blood pressure. Well, pattern here, renal vascular hypertension. What does that mean? Maybe there's a renal arterial stenosis resulting in increased blood pressure, secondary type. It could be a female less than 30. Your diagnosis there. Fibromuscular dysplasia. Greater than 50. What's causing renal arterial stenosis? Atherosclerosis. In addition, what are you going to look for? Well, you're going to try to see as to whether or not it's a primary or secondary. So renal vein, renin, becomes important for us. And for example, if you are thinking about a decreased perfusion, you can expect there to be an increase in renin, don't you? You expect the increase in plasma renin activity, renin vein or renal vein type of renin. If it's malaise, isolated lab, increased creatinine, here maybe once again renal arterial stenosis, and fatigue. And fatigue here to you should mean, oh, my patient, if it's kidney related, must be some type of normocytic anemia, non-hemolytic. EPO, chronic renal failure. Secondary diseases include your diabetes, nephropathy, that's huge. And this would then have objective measures such as effective glomerular filtration rate and glomerulonephritis being caused by ANCA. Other secondary causes such as something like your, what we talked about with granulomatosis with polyangiitis and company.